since we're all twos and threes, I'm sure everyone knows who Bertina is, so no need for introduction here.
Really, I think
twice in 1 week, Bert.
I know, Dr. A, but it's you won't see me in a while after this, don't worry. Okay, guys, let's go ahead and start. I'm gonna try to go very quickly over some topics because I know that we've been reviewing them multiple times, and this presentation is gonna be like a deja vu to the seniors because it's gonna be the third time that they're seeing it. So I'm just gonna try to focus on particular things that I know that they're very practical for you on the first 20 minutes, and the second 30 minutes of the presentation, we're going to try to do some interactive cases with an vent simulator. We have software I have here. One of the big advices I can give you guys for this presentation, particularly for the second years, I know that the seniors, they're already on the mindset that they're graduating and likely never going to use a ventilator again. Although some of my classmates told me the same thing in 2020, so you never know. That being said, for the second years, try to focus on the things that you really have questions about, and perhaps you want to expand more, because I know that when you are on non-medical units or are dealing with patients that are ventilated outside of the unit, you often don't have a lot of support, and you end up having a lot of questions regarding many things like this, particularly in the middle of the night. So try to answer those questions right here, because that's the objective of this lecture. So I always like to start with the general indications for mechanical ventilation, and I always like to divide them in 3 large groups, just so it's easy to remember. The first 2 apply to non-invasive, and usually the last one is just for invasive mechanical ventilation. The first one is very easy, right, guys? You have a patient that needs oxygen support or needs support clearing CO2. Straightforward. So you have a patient that is in max high flow and is desadding. Usually the next step is going to some sort of mechanical ventilation. Regarding CO2, similar way, right? You have a patient that has hypercapnic respiratory failure for whatever reason, for example, a COPD exacerbation. Going from a nasal cannula to a non-rebreather is not going to help at all, because what you need to provide is some minute ventilation support. The second one, which is a very important one, and I think that I always preach that this is the one I see a house staff failing to recognize the most often, which is increased work of breathing. I see it every time that they call a rapid for whatever reason, alter mental status, and they're focusing on the neuroexam, and they fail to see that the patient is using every single accessory muscle to breathe, because people don't pay enough attention to the work of breathing part. That being said, if you have a patient that has increased work of breathing for whatever reason, either pneumonia, pulmonary edema, COPD, what they need is some extra help with that low compliance that is giving them that issue. So what you have to do is provide them with mechanical ventilation as well, and positive pressure ventilation. The last ones, I put them here because these are contraindications for non-invasive ventilation, and therefore they become absolute indications for invasive mechanical ventilation, which is apnea, airway protection, and pulmonary toilet. In general, we don't like using non-invasive on patients that are not breathing. There are very few exceptions where we do this, but you have to remember that if the patient has no respiratory rate whatsoever, ideally that patient needs to be intubated. The same manner, if you have a patient that is vomiting and gushing blood, you're not going to slap a Bipap on there, right? Because they're just going to start aspirating everything. Or if you have a patient with frank pus coming out of their airways, if you just put a Bipap on them, it's going to dry up their secretions and start plugging their airways and causing atelectasis. So those are big no-nos for thinking about Bipap. Huge reminder about hemodynamics, and you need to be very comfortable with this. This can sometimes be a board question too, particularly because of the effects of positive pressure on the right ventricle. So on the left ventricle is very straightforward, and I like to put it as heart failure management 101. So the 3 basic principles of management of heart failure are very simple. You decrease preload, decrease afterload, and improve contractility. Positive pressure ventilation does 2 of these. They decrease the preload of the left ventricle, and they decrease the afterload of the left ventricle, therefore improving the function of the left ventricle. So if you have a patient with acute decompensated heart failure and cardiogenic pulmonary edema, high flow is not the best option for that patient, because that patient needs positive pressure in order to assist the function of the left ventricle, therefore improving the clearance of the pulmonary edema. So that's why this is so good for patients with heart failure. On the opposite side, if you have a patient with positive pressure ventilation and you apply it to the right ventricle, the effect is kind of the opposite. For preload, is the same. You're going to decrease the preload, which is not that bad, but the problem is the afterload effect, because you're going to be increasing the afterload. So the effect that this is going to end up having is kind of think of it as a pulmonary embolism. If you have a massive PE, what you end up doing is just causing a massive surge on the afterload of the right ventricle. Therefore, the stroke volume of the right ventricle drops. Therefore, the cardiac output of the right ventricle drops. Therefore, the blood pressure drops and the patient goes into shock. Very easy. Now, if you have a patient that already has, for example, chronic pulmonale from pulmonary hypertension, has severe PA pressures, and the patient goes into respiratory failure, you're going to see that many of the pulmonologists and intensivists are always very afraid of intubating these patients, because we know that the moment we intubate them and the moment we give them positive pressure, that patient will go into cardiogenic shock. And the reason why they go into cardiogenic shock is because you are really giving a surge of increase of afterload to a very weak right ventricle. So always take into account, whenever you think that someone might need to be intubated, always keep in the back of your head where this patient is at high risk for having pulmonary hypertension, and is that something you should be thinking of. Now, a quick overview of non-invasive ventilation. Remember that this is usually Bipap or Cpap, and it just provides positive pressure without someone being intubated. Take into account that generally the masks that you have on the top on these three, which are, facial masks, nasal prongs, and nasal mask, are only used for OSA. Full face mask and the head and the helmet here, these are used for Bipap. I've never seen a helmet being used in the US, although the Europeans love it. That being said, take into account the general contraindications for using non-invasive, which, as we talked before, apnea, inability to protect your airway, facial trauma, and patients with high aspiration risk. Usually my thought process, whenever they call me for seeing a screen for someone with respiratory failure, is that if the reason for the respiratory failure is aspiration pneumonia, that patient already has a high aspiration risk, right? So if that patient is already having aspirated and already has a blocked airway, and now I slap a Bipap on that patient, I'm just going to make things worse. So it makes sense if you want to start a Bipap on that patient as a bridge until the patient is in the unit so I can intubate that patient. But don't start a Bipap on that patient because you're waiting for the patient to get better, because that will not happen. So usually those patients just need to be intubated. I'll talk to you about that later, Noor. It's a long explanation if we have time. That being said, severely impaired consciousness is a relative contraindication just on two circumstances. One, narcotic overdose, and second one, CO2 narcosis. Why is that relative? If you have someone that is massively obese and has OHS, OSA, and they start getting altered because their CO2 is high for whatever reason, if you put a Bipap on them, you improve their ventilation, you improve clear the CO2, their mental status improves. So doing a trial of Bipap in that scenario makes sense because you're fixing the issue that is causing the impaired consciousness with the Bipap. In a similar way as well, if you have a patient with a narcotic overdose and the patient is kind of apneic, if you want to do the Bipap in the meantime that you start a Narcan drip to fix that narcotic overdose, again, it makes sense because you are bridging to something. But if you have a patient that has an impaired consciousness because, a benzo overdose or a stroke or hepatic encephalopathy, putting Bipap on that patient and hoping that the patient will get better is wrong. So the right thing to do would be that that patient would need to be intubated. Now, just a brief reminder of the basic respiratory curves that differ between Cpap and Bipap. And remember, Cpap only provides exhalatory support. And the reason why I say exhalatory support is because it provides no invasive, no inspiratory support whatsoever. So don't expect Cpap to help with your tidal volume or your minute ventilation in any way whatsoever. Whereas Bipap, the whole objective of why Bipap exists is to provide inspiratory support. It wants to improve the tidal volume. And if you improve your tidal volume, you improve your minute ventilation, therefore you improve your CO2 clearance. That's the objective, and that's the difference between both. And from a practical standpoint, remember that Cpap it's pretty much PEEP and it's pretty much EPAP in the Bipap language, whereas BiPAP is IPAP or pressure support or pressure control. Now, general indications, and this is going a little bit farther into advances, is that CPAP, we only use it in 2 scenarios with real world indications. One is OSA and the other one is when you need airway stenting. What am I talking about airway stenting? For example, if you have someone with tracheobronchiomalacia, or you have someone with EDAC, with excessive dynamic airway collapse, meaning their airways are too floppy posteriorly and they start to collapse, then those patients need to sleep with CPAP, otherwise their airways collapse when they're sleeping and they start retaining. Whereas BiPAP, the way I look at it is that it's good for providing minute ventilation support, meaning if you want to provide PEEP and you want to provide inspiratory support, that's the objective of BiPAP. That's what we use BiPAP for, that we don't use CPAP for. So take that into occasion when you're selecting to use one of these. That being said, all of you guys have become very familiar with COVID and I have seen a bunch of COVID patients, and you see very commonly that one phenotype of COVID patients that we see is that they are extremely hypoxic, but they still are able to maintain a very effective minute ventilation. So you see patients that are hypoxic, but are breathing very deeply and are breathing very fast. So many of these patients, what ends up happening to them is that they're breathing at rates of 30 with volumes of 1,000. And the patient already failed high flow with no rebreather, and now you want to start non-invasive until we intubate that patient. So if that patient that already has a very high minute ventilation without no effective shunting, you put them on BiPAP, what you're going to achieve is that you're going to be giving them way too much tidal volume, and now the patient will develop an even worse respiratory alkalosis. So if you want to just bypass the inspiratory support and just want to provide them with PEEP and oxygen, then CPAP becomes more effective in that phenotype. That's a little bit more advanced, but I know that for many of the seniors, it's going to ring a bell because we see many of these patients with COVID presenting themselves with this phenotype. Now, basic variables of the ventilator, you all need to be very familiar with. And I told the interns that if they could remember one thing from my 1 hour presentation, it's this basic thing here on the bottom. When you have a ventilator and what you want to improve is oxygen, you do it through Fio2 and Pip. When you want to improve the minute ventilation, you do it through respiratory rate and tidal volume. Like that simple mind frame should be bread and butter to you by now. And you should be very comfortable understanding this concept. Because you should never be thinking of improving oxygenation by increasing your respiratory rate. That does not make sense. So keep in mind that this is the basic mind frame of how we improve oxygen and CO2. Now, FiO2, guys, basic, remember, less is more on patients that are chronically on a ventilator. So we don't like having them setting 100, we like setting them between 90 to 94. But if a patient is crashing, you don't negotiate with oxygen. You crank up the oxygen to the maximum amount you can do, you stabilize the patient, and then you can start weaning it off. Tidal volume, in general, remember 6 to 8 cc/kilograms of ideal body weight. Feel very comfortable calculating the ideal body weight is on MD Calc, or if not, some of the cows in the ICU have the tables glued to the back where they're going to give you the ideal body weight based on the age and height. PEEP is positive end pressure. We're going to talk a little bit more about that to more extent. And respiratory rate, it's whatever the patient needs. Just always be mindful that the patient is not breath stacking when you start to increase the respiratory rate. Now, talking quickly about PEEP, remember that the main objective of PEEP is that it's going to provide with alveolar recruitment. So it's going to open up many parts of the lung that are closed. And the typical example I always give of that is this video that I'm sure many of you have seen at least once if they have worked with me. So this video, what it provides is an image of, these are rabbit lungs, and they're being ventilated at different volumes with different PEEPs. And what you're going to start seeing is that the more PEEP is provided to the lungs, many parts of the lung that are atelectatic are going to start expanding and opening. And what this image is obviously providing you right now is the basic principle that more PEEP leads to more recruitment. But one of the very interesting things that you see here is that the moment you lower your PEEP again, many of that areas of the lung end up being still recruited. So this is providing you a very graphic image of what PIP does, which is recruitment. In that same note, if you have a patient with ARDS that is intubated and ventilating with a PIP of 14, and for whatever reason you're doing an IJ and you don't notice the system gets disconnected, everything is going to get de-recruited. And the moment everything gets de-recruited, that patient is going to crash. And then the problem is that you're going to start providing them with oxygen all over again. And even if you give them that FiO2 of 100, is the oxygen status of the patient will not improve immediately. So that's why protecting that recruitment that you did is very important. And whenever we win PIP in the ICU, in ARDS patients, I'm sure you have seen that we're very careful with how we do it. We go little by little, because we know that if we go from a PIP of 18 back to 5, we're just going to de-recruit all the lung, and then it's going to be very difficult ventilating that patient again, particularly in patients with ARDS that have very high elasticities. Now, it's important to talk about the effect of PIP on the shunt fraction, and this is a very looks like a very complex topic, but trust me, it's not that bad. And the reason why this is important is because the more shunt you have, the less responsive the patient becomes to oxygen. Because no matter how much oxygen you provide to the patient and no matter how much you're trying to ventilate, you're having a huge shunt fraction. The more PIP you provide, you reduce that shunt fraction by recruiting alveoli that is collapsed, opening it up, and allowing ventilation in that open alveoli. This graph is very important because it shows you two important messages. One, that PIP provides an improvement on the shunt fraction by decreasing the functional residual capacity. And the second one is that after you achieve that maximum well-recruited lung, if you keep providing more PIP, then that excessive PIP starts having the opposite effect. And what it starts doing is over-distending the alveoli to the point that the capillary starts to get squished, and now you have a VQ mismatch. So PIP is always good, but you have to be mindful that there's a limit to how much PIP we can give. And because of that is that we always have the ARTSNet tables, so you guys can see and have a mental mind frame of what's the FiO2 to PIP relationship. Because we don't want to be having patients with a PIP of 25 and that's the wrong PIP for that patient, because then you're going to start hurting that patient. The other important relationship that you have to understand about PIP is that whenever PIP is necessary, usually falls within the scenario of patients that have very low lung compliance. Meaning, for example, patients with ARDS or cardiogenic pulmonary edema, which is our bread and butter in the CCU and the MIC. So PIP, what it achieves with these lungs is that it improves the compliance. So always remember that the main pathophysiologic mechanism of both cardiogenic pulmonary edema and ARDS is that drop in the compliance of the lung. The lung becomes very stiff and very difficult to ventilate. So the more PIP we provide to those lungs, the more those lungs become more compliant and easy to ventilate. I don't know how much you remember of your basic respiratory physiology, but one of the examples they always used to give us when we were learning basic physiology is that when you're trying to inflate a balloon, the most difficult part of the balloon to be inflated is always the first second, right? Because breaking that excessive compliance at the beginning becomes very difficult, but once the balloon becomes more inflated, the balloon easily becomes inflated. So PIP is doing that exact same thing. It's just providing some initial inflation so the extra inflation becomes easier to do. Okay, before I move, any questions here? Okay, quick, modes of ventilation. So modes of ventilation belong to two large groups: controlled mandatory ventilation, which, as you know, the vent is micromanaging everything, and assisted or support mode of ventilation, which you only use on two scenarios. One, the patient is having an SVT, and we're trying to see if we can extubate that patient. Or two, we have a patient that we expect a prolonged weaning from the ventilator, and we want to provide kind of like crutches or training wheels to the patient to wean them from the ventilator little by little. So those are the only two circumstances where we really use support modes of ventilation. I'm not going to go into depth about the difference between pressure, volume, and PRVC, because I know you have discussed this at length every time you're in the MICU. But remember that the main difference between pressure and volume control is that in pressure control, you set up a pressure, and in volume control, you set up a volume. That's pretty much it. Now, as a reminder, these are the basic parts of the screen. And one of the things I used to tell you ad nauseum every time we were on the sim lab is that remember that whatever is on the x-axis is what we control, and whatever is on the y-axis is what the patient is doing. So the typical telltale of an intern in July is that you ask them what is the respiratory rate of the patient, and they go and tell you whatever is here on the x-axis, because it's the first thing they read. And you start seeing that by the end, as the year starts to move forward, the interns are realizing that they have to read the rate from the y-axis. So for all of us that we have been doing this for a little bit longer, we don't have to make that mistake, and always pay attention to whatever is on the y-axis first. Remember that basically the yellow numbers and the yellow graphs are pressure, green is flow, and blue is volume. You can match the inspiratory cycle with the flow and the volume here, and take into account that the inspiratory phase goes up, then it comes back to 0 when it reaches maximum the inspiratory volume, and then when you start exhalating, it just drops down here and then returns to 0. And it's very important that it returns to 0, guys. You always have to see the expiratory flow returning to 0. If you don't see that, the patient is breath stacking and you're doing something wrong. Now let's talk about very briefly about the Bipap screen, because I feel that you guys as seniors and second years end up dealing with that screen, this screen here, way more often than we do with the servo ventilators. Now, Bipap, I think that people overthink it way too much, when in fact it's nothing more than a pressure controlled mode of ventilation. That's it. All that you're doing is providing a patient with a like assisted mode of ventilation that is being controlled through pressure. So here on the bottom, what you have is what you are controlling as a provider, whereas what you have on the top is what the patient is actually doing. So you see here very simple parameters such as rate, tidal volume, minute ventilation, positive inspiratory pressure, which by the way, this 11 is wrong, because if the patient has an IPAP of 10 and an EPAP of 15, how much should be the total inspiratory pressure of the patient? 15, right? Makes sense. So this 11 doesn't, so that's wrong. And that's kind of like the simple logic that you guys should have. Now, the interesting thing about Bipap is that it adds a variable extra that usually the invasive ventilator doesn't have, which is leak, which is the one here. So always remember that the Bipap needs to have a leak. It doesn't have to be a lot of leak, but they need to have a leak. Why is that important? Because even though there's an exhalatory valve on the Bipap, it's not enough for all the CO2 to be exhaled. So the patient needs to have around 25% of leak. If the patient does not have that leak, then the patient starts re-inhaling their own CO2. So far in my fellowship, I've seen this case twice, and you're gonna see that these are the tubings of the Bipap, and you're gonna see that the tubings have this white port here, transferring port here. I don't know if you can see it. It's kind of like an exhalatory port here. Do you guys see it? Yes. So this exhalatory port, it's always open. And the reason why it's always open is because that exhalatory port is made there on purpose to provide assistance to the patient in order to always have some leak. So I've seen it twice already that they call me for rapids, or they call me to see patients that have COPD, they place the patient on Bipap, and now the patient has a worse mental status as they started the Bipap, and they're like, what is going on? You go examine the patient and the ventilator, the Bipap is alarming low leak. And the reason is that someone that was way too eager beaver closed this here, and then the patient started re-inhaling their own CO2. So that never should be done. The next question that you would ask me is, why are we doing that? And why does this exist? For patients that have, very large beards, or the mask doesn't fit well and there's too much leak from the face, if you cannot control the leak from the face, then you close this port here. That's the whole objective of that port. But if 95% of the patients, they don't need that. So this has to remain open. So this is a point that I wanted to touch with you guys because you guys are ACs or about to become ACs. Now, the common types of alarms, we're going to go very quickly over them, but remember, low pressure, low volume means disconnection, high pressure usually means obstruction on broad terms. Apnea, you're only going to see it when the patient is in spontaneous modes of ventilation, and you can see apnea alarms on bipaps as well. And asynchrony, there's not an alarm, but if you feel that there's something that doesn't make sense on the ventilator and doesn't look pretty, just ask for help. Kind of like see something, do something kind of scenario. Now, peak and plateau pressures, I think that we have to talk a little bit more about them because it's more of an advanced concept that particularly the seniors need to be comfortable with, because this can be a board question, particularly what high plateau means. So remember that a peak pressure is just general total pressure. It's not meaning anything. It just tells that the total pressure of the system is elevated. So if the plateau pressure is elevated, the peak pressure is going to be elevated too. But if the plateau pressure, which is a synonym of compliance, is normal, the peak can still be elevated. So you have an elevated peak with a normal plateau, that means it's a resistance issue, meaning bronchospasm, secretions, biting, clogging, whatever, but means an issue with the pipe. But if the plateau is elevated, then it means an issue with compliance, an issue of the balloon. And the reason why we always tell you to be mindful of this is because remember that for ARDS, one of our treatment goals is always to have a plateau less than 30. So if you guys are setting up ventilatory parameters for a patient and you're providing a tidal volume that provides a very high plateau, you're damaging that patient, you're hurting that patient. Similar in the CCU, you have a patient with cardiogenic pulmonary edema, the patient's lungs are completely fluffy. They're setting up the tidal volume and you set up a tidal volume of 8 cc kilograms because the patient is hypercapnic and you want to help the CO2, but that's providing a plateau of 45, then you're injuring that patient. So you have to be mindful of that when you're setting up parameters for the ventilator. Now, how do we measure the plateau? Remember that there's a button on the right lower corner that you hit. It's called inspiratory hold maneuver. And what it does is that it allows the ventilator to stop completely the flow at maximal inspiration. Therefore, the gas redistributes in all the parts of the lung. And it allows you to see what is the actual pressure of just the respiratory system. Remember that you have to click next page to see the number smaller like this on the servo ventilator, or you're not going to be able to see a plateau. So you have it like on the first screen, like this one. You're not going to see a plateau. It has to, you have to click next page to see it like this. On that same note, we're going to quickly talk about auto PIP, which I think it's also very important that everyone feels comfortable understanding. And auto PIP is nothing more than an intrinsic PIP that a patient develops. And try to picture this image of an asthmatic breathing very, very fast, and so fast that they cannot fully exhale all the air in their lung. So what ends up happening is, just for fun, try to do this exercise. You breathe in and then you breathe out, but don't fully breathe out your air. And then you breathe in again, and then you breathe in again, and then you breathe in again. And you just keep stacking air over air over air over air. And then all of that air that ends up being stacked in your lungs ends up creating an intrinsic PIP. So that intrinsic PIP, the moment it starts becoming too much, it starts becoming numerically significant, that it starts affecting your hemodynamics. So the typical scenario that we always talk about in pulmonary is that they call us to evaluate a patient with COPD or asthma that is intubated. The patient, they have it breathing at 25 breaths per minute because the patient was hypercapnic, and now the patient is hypotensive and dysatic. And they're like, oh, what is going on? And you clearly see the ventilator and you see this graph right here. What is happening? Clearly, the patient is breath stacking because you are making the patient breathe way too fast. So by doing that, you're not allowing the patient that has airway disease to fully exhale. Therefore, they stack gas inside, they stack air pressure inside, and it also affects their hemodynamics. So usually people, when they see an asthmatic that gets hypotensive on mechanical ventilation, for some reason, the first thing they think is, oh, it's a pneumothorax. It's never a pneumothorax. It's most of the time always auto PIP that a provider is failing to recognize they're iatrogenically creating. Now, we're going to touch very quickly on ventilator-induced lung injury. And I think that this is very important for everyone to also feel a little bit comfortable understanding. And the best mechanical ventilation is no mechanical ventilation. We always preach that as intensivists. It's always bad to want to keep the patients for long periods of time on positive pressure because we end up harming the patients. The ways that we can harm them is, for example, with long volume ventilation, we can cause atelectotrauma. Another way we cause atelectotrauma and create areas of atelectasis by providing no PIP whatsoever. That's why we always keep a PIP of 5. On the opposite side, if we over-distend our lungs and we give way too much tidal volume, we can cause hyperinflation, which causes air leaks. So the air leaks lead to pneumothorax and pneumomediastinum. And again, this is all caused by giving too much volume to the patients. In the end, all of this is going to lead to structural lesions and microscopic lesions, which lead to atelectasis, cellular damage, and eventually all of these leads to increased alveolo-capillary permeability, which leads to biologic alterations. And this is very, very important because all this also leads to bacterial translocation from the lung to the circulation and leads to SIRS and multi-organ dysfunction. So sometimes people ask, why can patients in the ICU get infections? And they always think of lines and aspiration, but you gotta take into account that there's also a lot of bacterial translocation from the lung, from the mechanical ventilation we're providing, and also from the gut. And those are two huge sources of infection that the patients can get, and there's no way to avoid them besides removing mechanical ventilation as early as possible and feeding the patients as early as possible. Now, I was going to talk about this, but we're running out of time. So we're going to start with cases. I think that at least all my attendings are very good about talking of liberation of mechanical ventilation. So that's going to be a topic you're always going to be talking about whenever you're in the MICU. But we're going to move on to cases, and we're going to do 4 or 5 cases. What I'm going to do is that I'm going to allow one of you to offer themselves to answer some of the cases. The cases go in increasing level of difficulty. So the case 1 is very easy. Case 5 is a little bit more difficult. Sananda got mad with me because I said I was going to call people by names, and she said that that is not nice. So what I'm gonna do is just allow you guys to offer to answer the cases. And I see Patrick is already smiling and like willing to answer the first one. Okay, who's doing the first case? We have 20 minutes, guys.
I can go.
Awesome. No. The resident and the fellow are gowned up doing an IJ that has been taking them half an hour. The patient is completely sedated and paralyzed. They call you to help because the ventilator is alarming and they cannot see the screen. So always a good idea that whenever you're doing a procedure on the neck, turn the monitor of the vital signs towards you and turn the ventilator towards you, right? Because then you're going to be gowned up and not going to be able to see anything. So it's just a tip of advice, because otherwise this happens. When you enter the room, you see that the patient is desaturating and the ventilator is alarming low volume. What is going on?
Just like to make sure that the circuit is connected, because sometimes because we move the patient head, sometimes it get disconnected, or if there is leak anywhere.
In which parts of the ventilator circuit would you look for leak?
Starting from the connected with the ventilator till to the balloon of the tracheal tube.
So the first ones are those, right? You always start with the endotracheal tube cuff to make sure it's inflated, and you can always touch the small, tiny balloon that is connected to the tip of the endotracheal tube. If it's inflated, it's going to feel puffy. Then you make sure the endotracheal tube and the ventilator circuit is connected. Basic one that always gets disconnected when people are doing IJs. And then you follow the ventilator circuit all the way to the ventilator to make sure every single part of the ventilator is connected as well. So basic question, guys, very good. start all the way from the patient and work yourself back from the ventilator. And remember that the ventilator has two large pipes that are the inhalatory and exhalatory ports. And the inhalatory port always goes through a humidifier, which is kind of like, you're gonna pay attention next time you see a ventilator, and there's kind of like this mini thermos connected to a ventilator. That's the humidifier. Okay, who's doing the next case?
I'll do it.
Awesome. Oh, good. Future PCCM fellow. Okay. So 60-year-old male with AFib and anticoagulation admitted for upper GI bleed, intubated for airway protection due to hematemesis. The patient is admitted to the MICU status post-embolization. You know that it was in the middle of the night because otherwise GI would have done it. Normal vital signs were recurring phenylephrine drip. The ABG has a pH of 7.19, PCO2 of 50, bicarb of 10, lactate of 8. Try to remember these numbers. The weight is 120 kilograms. The patient is kind of husky. And the height is 180 centimeters. What changes would you do to the vent settings and why? And let's take a look at the vent. So this is the vent that you're getting from the patient. And that's what you have in front of you.
No, I can't see the vent.
Can't see it.
Wait 1 second and I'll fix that. You should see now.
Yep. Yeah, we
Okay, so I can increase the respiratory rate, which is 12, but he's also on a low tidal volume based on his weight. I don't know if that's his, I mean, we have to calculate the ideal body weight because the lungs are not like, you have
So
to
you can ask one of your co-residents that is hanging in the ICU with you to calculate the ideal body weight while you do the other
okay,
changes.
so who's hanging in the ICU right now?
I can help.
In the meantime, I think I would just increase the respiratory. I can get
Joe already answered in the chat the ideal body weight.
How much is it? 75. Awesome. So how much tidal volume do you want to do?
hold on, let me pull up a calculator. 75 times 6, 450.
Okay, let's go up to 450. Okay, 456. Okay, what else?
So, I mean, I just made one change. I wouldn't change two things at the same time. I would just maybe check another ABG and see how the PCO2 is and the pH.
Do you think a rate of 12 is physiologic for this patient?
Well, we can increase to 14, I guess.
If you had a patient that is not intubated, not sedated, not paralyzed, with severe metabolic acidosis and a pH of 7.1, lactate of 8, what rate would you expect to see clinically in that patient?
You want him to be tachypneic so he can compensate for the metabolic acidosis, right?
Correct. So what do you want to do?
Well, in that case, I will increase to 20.
Okay. Let's go up to 20. 20.
Okay.
Now, with a tidal volume of 450 and a rate of 20, let's see how much our change of minute ventilation is going to be. But in general, for a patient that is hypercapnic, you want to push them a little bit more. That is not that is hypercapnic and has acidosis, and you want to compensate that. You want to push that minute ventilation. And the big number I always keep in my head is that I want to have at least a minute ventilation of 8. That being said, looking at the other numbers here, another thing that I would pay attention, and this can be something very easily missed because we do too much PRBC in our hospital, so we sometimes lose track of this because PRBC auto-regulates this. But let's look at the IE ratio here.
Yeah, we need to adjust the timing of the inspiratory as well.
Correct. So what is the IE ratio that we see here right now?
1.9 to 1.
1.1 to 1. What is an IE ratio we would want physiologically in any patient, any normal human being?
I believe that the expiration should be longer than the inspiration, especially for patient who is retaining CO2.
Not necessarily because they're retaining CO2. The question you guys have to answer is, what is the normal aeration?
I think it's 1 to 3.
More or less like that. Yes, it's 1 to 2. So how do we improve that I ratio? And the way we do it is by reducing our inspiratory time. So we have to drop this. And we're gonna go all the way to 1. And the moment you achieve 1, look at what happens to the I ratio. Goes to 1 to 2. So you're allowing a better exhalatory phase, because one of the things that you were seeing here, that we were starting to breath stack, because you were having such a short exhalatory cycle that there was no enough movement going on. Let me show it to you again. So we're gonna do a little bit of an excessive case. Let's do 5 seconds of inspiratory time, just so you can see how it looks. I hope I don't break the simulator. Please don't break the simulator. You see? There's no exhalatory time here. So you have to take into account that the way you fix that is by reducing the inspiratory time. Okay. Kind of broke the simulator. Okay. Any other changes you would be doing?
You just, at one point you had the minute ventilation at 8, how you want it. I don't remember what changes. Okay, now we have it.
Yeah, so ideally I would tell you I want it at 8. And for me, you know, a rate of 20 is not that high. I think that most of our patients in the hospital have rates of 20, which is not normal, but it's still how it is. So there's no reason why in someone that doesn't have asthma or COPD, you cannot be a little bit more aggressive. Like you can safely go up to 30 and the patient will be fine. And the thought process behind this, and I will tell you, is that what you want to do is fix that dangerous pH. Because acidosis is bad and we don't want to have patients being very acidotic. So we have to fix that a little bit better. And we have to be more aggressive at fixing that. So going up to a rate of 30, if the patient tolerates it and there's no breath stacking, should be something that you should reflectively do on these patients and try to fix that acidosis. The only patients in who we are always afraid to make them very tachypnic are patients with COPD or with asthma. Any other than that, just go up on the rate and allow patients to breathe out. If you get a patient in the ED with a DKA and a pH of 7.15, it's going to look like this. The patient's breathing is going to look like this. They're going to be breathing at high volumes and they're going to be breathing very fast. So don't be afraid to simulate that on the ventilator. That being said, I do want to say that you mentioned something very important, which is checking a new gas. So if you did changes to the ventilator, you increase the tidal volume, you increase the rate, all of these are things that are going to change the CO2. So you have to do a new gas to make sure that the CO2 is moving in the right direction and the pH is not getting worse. The other thing that we always preach is that we don't like FiO2s of 100. So if you have a patient that is not hypoxic, this patient is in the hospital. Why? Because of a GI bleed. So likely we're going to assume that the patient has normal lungs. Therefore, I don't think the patient needs an FiO2 of 100. We can safely go down to 60 and then switch it to 40. The patient is going to be fine. Okay, any questions with this case? Awesome. Let's do the next case. Who's up? Who's next?
All right, I'll take the next one. That's
okay. So 75-year-old male with history of COPD and bronchiectasis admitted for, wait, let's do this one. We're running out of time. New admission to the MICU straight from the ED. 55-year-old male with type 2 diabetes come with COVID pneumonia and ARDS. As bread and butter as it gets. Initially with mild ARDS, but the patient has been boarding over 12 hours in the ED and now it's getting worse. The SAT is 88%, the FiO2 is 100, the PP 5. The last ABG you have is what you're seeing there, which is someone pH of 7.1, PCO2 of 60, and PO2 of 49. let me change the ventilator here. And what changes would you try to do to the vent settings and why? And this is your vent.
Okay, so first I would increase PIP
Okay.
to 7 because I don't want to do it too much. The other problem is he's retaining his PCO2 of 60 and he's acidotic as well. So that means that I would change the tidal volume as well. But I'm going to do low one. I'm going to lower the tidal volume because we need to use 4 to 6 instead of 6 to 8 since RDS.
So
Well,
how much do you want to do?
what was his weight again?
I don't remember. Let's say 75 kilograms and a height of 185.
So 75 kilos, if we use 4 instead of 6 to 8, that would be 300. So tidal volume 300. So
Are you sure that that's the body weight we need to use?
we need to use ideal body weight.
How do we get the ideal body weight?
From height and sex.
Yeah.
Correct. So you can ask someone to get the ideal body weight, or you can use
Joe
your...
said it's 80, so that comes to 320.
Okay. And you want to do 320 because it's 6 times 80 or 4 times 80?
4
What are you
times.
doing? Okay, so you're going to do 4. Okay.
Yeah, because it's ARDS, I'm going to choose to use low tidal volume.
Okay. So we talked about the tidal volume. We have 3 more settings, and we talked about the PIP, which you wanted at 7. The patient is still deciding. Do you want to do something to improve the sets a little more?
I would increase FiO2. It's at 58. So I'll just crank
the
it.
FiO2
over.
right now is 60.
Oh, it's 60. So I would increase it to 100.
Okay, let's be aggressive.
Yeah.
Aggressive. Aggressive.
Let's
Okay,
see
so
what
we go
happens.
to 100. Okay, so now you talked about the PIP, you talked about the FiO2, the tidal volume. What are we missing?
The respiratory rate is at 30.
Okay, is the patient breathing comfortably at 30? Meaning, is the patient breath stacking?
No.
You can say macroscopically no, right?
No, he's not. Yeah.
Like if you start splitting hairs, you're gonna say that yes, but in reality it's not. Does the patient have a good IE ratio?
No. Just it can improve a little bit.
So what do you want to do?
Change inspiratory time.
Okay, what do you want to do with it?
Lower it.
Okay, how low?
It's 0.79. Let's do 0.5.
0.5. This is not rocket science. Here in medicine, we just try things, we see if it works, and if it doesn't work, we try another one.
Yeah.
So it's 1.28. Okay.
Yeah.
A little bit better, right?
A little bit better.
And you can say that maybe let's see 0.6 and let's see what they do. 1.23. A little bit good. You also need to have some inspiratory time, right? Because otherwise people are not gonna exchange gas. But it looks much better now. So now you have a tidal volume of 320. You have an FiO2 of 100. The SAT is starting to improve. Now it's 97%. The peak is 24 and the plateau is 21. Do you like that plateau?
Yeah, as it's less than 30. Oh, sorry, the peak is the one that's supposed to be less than 30.
Are you sure of that?
No, I'm not sure.
That's a good answer. Yes, it's a plateau. So we like our plateaus less than 30. So
Okay.
do you remember what maneuver we need to do to measure the plateau?
The plateau pressure, inspiratory hold.
Correct. So we do our inspiratory hold and it gives you a plateau of 21. Now, I guess that the last question is here. Now the patient is starting well. You have a new good tidal volume, you have a good plateau, you have a good respiratory rate. The question I would ask you is, do you feel the PIP should remain at 7 or can we go up on the PIP, and how high should we go up on the PIP?
We can go up to 10, and then if we maintain saturations, we can try to reduce FiO2.
So the patient will continue starting well, right?
Mm-hmm.
When we go up on the PIP, what can happen to the patient that we're afraid of? Let me rephrase it. Why do we always increase the PIP slowly and not just crank it up to 20?
Dynamic instability.
Because you can.
Say that again, Joe?
Hemodynamic instability.
Correct. Yes, right? Because our fear is that if we're very aggressive with increasing the PIP, we're going to drop the preload of the patient too aggressively as well, right? So we go up from 5 to 20. We're just going to squeeze all the preload out of both ventricles, and then our stroke volumes are going to drop. And don't be afraid that many of the patients with mechanical ventilation, you start giving them too much PIP. And then what ends up happening is that you need to start pressors on them or give them some fluids to kind of like fix that issue a little bit. That's nothing wrong. That's the right management to do. So you're going to see very often that many patients we have with ARDS, they end up require sedatives that are vasodilators, and they're requiring a lot of PIP. Therefore, if you give sedatives and that are vasodilators and PIP, what do you expect is going to happen to the blood pressure?
It's going to tank. Yeah.
Correct. And how do you recover that blood pressure?
Reduce PIP.
We don't want to do that, right? Because the patient has ARDS. So if it's immediately and the patient is crashing, yes, fine. But in reality, what the patient needs now is a vasopressor.
Mm-hmm.
I will joke around that the patient has a levofed deficiency, because that's what you need to give the patient to fix the acute issue that is killing the patient. And don't be afraid to sometimes give some fluids to these patients as well. Because if the hypotension is being caused by a preload dependent issue, giving fluids is nothing wrong. Obviously, you don't want to keep drowning the patients, but eventually, if you give them a bolus a patient and the patient is still hypotensive, then that's just a sign that the patient needs a vasopressor. Now, I think this is very good. The last teaching point I'll give you with these guys is that don't forget about your ArtsNet tables for FiO2 and PIP. And why is this important? In Eric's case, we're having a patient with severe ARDS requiring an FiO2 of 100. And the question that you ask yourself is, how much PIP should I be giving this patient? And the way you answer it is based on how much FiO2 the patient is requiring. So if you have a patient that is requiring an FiO2 of 100, looking at that table, we always in our hospital use the low PIP to high FiO2 ratio tables. And what you're going to see is that patient should technically all the way in a PIP of 18. And that's not abnormal for that patient. That's the expected thing for a patient with severe ARDS, that we need to get them to that point. Because remember, PIP is good for these patients. It reduces functional residual capacity and improves compliance. So if you receive a patient with ARDS in your unit and the patient is requiring an FiO2 of 100, you can go from 5 to 10 on the PIP and then start to increase it on 2, 2, 2, 2 to try to start coming down on your FiO2. Once you start coming down on your FiO2, you can start coming down on your PIP as well. My general approach to ARDS patients is that until the FiO2 is 60, I don't touch the PIP. Once I reach an FiO2 of 60, I can start downgrading the PIP. But I never like touching the PIP until the FiO2 requirement of the patient is between 40 and 60. Because the way I look at it is that these patients, even though their lung is healing, the compliance is still very low. So they always keep requiring that high pressure. Have one more case, but I think I ran out of time. So we're going to wrap up here. Any other questions?
Feel free to unmute yourselves, put it in the chat. I don't know. I know Nora had the initial question about why it decreases LV afterload. I know you had mentioned preload. I don't know if Nora was talking specifically about afterload and if you mentioned it, but if not, then I don't see any other questions in the chat.
Okay, so answering Nora's question, honestly, the reason why the afterload is decreasing in the left ventricle it's a little bit more complex to understand why it happens on the right. On the right, it's very easy, right? You squeeze the capillaries of the lung, therefore that's why the afterload decreases. The left ventricle, what it does is that it reduces the surface tension of the left ventricle and helping the left ventricle expand. Therefore, it improves how much blood flow is going from the left ventricle to the aorta. So it pretty much improves the gradient between both structures. That's my understanding of why that happens. The last case I was going to give you guys was a patient with asthma breath stacking. But we'll save it for another occasion. I know that for now, I know most of you guys are likely tired, bored of dealing with mechanical ventilators, but just try to remember how much that this knowledge is very useful, because when there's an emergency, this is the first thing you have to troubleshoot, right? They call you to a rapid or a patient that is vented on the floor, which it keeps happening, or they call a rapid to the ED or a patient with asthma that is getting hypotensive while intubated. You're alone in the unit, or you're alone in the CCU, and you have to troubleshoot these things. So always try to feel very comfortable dealing with these issues. I strongly encourage you guys that when you're in the unit, in the medical unit, try to go over the vent and try to do the vent changes yourself. Get familiar with using the knobs, get familiar with putting people on SVT, be very familiar with switching back to a regular mode of ventilation, because you all have to be very comfortable doing these things, because you are the frontline providers that are responsible for doing this. Luckily, in our hospital, we have amazing ICU nurses that can do all of this. Unfortunately, their respiratory techs are also great, but they're also very stretched thin. So sometimes they are not easily available to help. So you guys have to be able to do these changes. So I'll finish here, and I'll say that any questions, you always feel, oh, you have something, Eric?
Yeah. So if I go by the logic that Cpap is a continuous positive airway pressure, meaning that it pushes positive air into the lungs of the patient, how does it only do expiratory support?
By the same explanation, right? Because let me show that graph again.
I would think it pushes positive air.
Yes. So are you seeing the graph here?
Yeah.
So this is the difference, right? Because it's just providing you the PIP, positive end expiratory pressure. Obviously, the inspiratory pressure is higher, but when you subtract the inspiration from the exhalation, the delta remains the same. Therefore, because the delta between end inspiration and end expiration didn't change, the amount of tidal volume you're producing doesn't change. The only thing that is changing is how much PIP you're having and how much alveolar recruitment you can get from that. But the
I see.
effective tidal volume the patient is doing is the same.
Okay, I see. That makes sense. Thank you.
And that's why I gave you the example of these COVID patients that are, very hypercapnic, because not very hypercapnic, have severe respiratory alkalosis because they're breathing so fast. But they're hypoxic, so we place them on Bipap. So the moment you do give them Bipap, the tidal volumes go up to 1,500. And that patient starts getting severe respiratory alkalosis. And for anyone that has had alkalosis ever in your life, it feels horrible. You start having a lot of headaches, and it makes you feel like you're passing out. So to avoid that, Cpap is more effective because it provides no tidal volume support.
Okay. I see. Thank you.
Okay, guys. I'll leave before the chiefs kick me. Feel free to always reach out if you have any questions, and always talk to your friendly PCCM fellows that we're always happy to help teaching with any of this.
Gracias, Dr. Great lecture as always.